Okay. So I have titled this as complete or incomplete. I'm presenting a 24-year-old male who's a college student who presents with low-grade fevers, shortness of breath since 1 month, multiple joint pain since 1 month, and significant weight loss for the past 2 months. So coming to the HPI, the patient says he has a low-grade fever. There is no chills or rigor that the patient noticed, and there is no significant improvement with any of the oral antipyretics. Subsequently, he also noticed he has a progressive shortness of breath, and currently he is able to walk only 2 flights of stairs, after which he is breathless and has to stop multiple times. And there is association with this episode is associated with episodes of dry cough for the past 15 days. And coming to the multiple joint pains, these joint pains were involving predominantly the small joints, predominantly the wrist, hands, and the lower limbs in the feet. And there is no swelling or redness of the joint, and there is no stiffness of the joints, and there is no early morning stiffness. And the patient also had subsequently, just prior to the hospitalization, he had 2 episodes of streaky hemoptysis. Patient denies any trauma, any skin rashes, any ulcers, any feature suggestive of a connective tissue disease like Raynaud's or any joint deformities, photosensitivity, etc. I think I'll stop.
Thank you, EJ. Hans, we've gotten so much information, a lot of concerning symptoms. What do you want to comment on?
Yes, I would like to start with fever, but then we have shortness of breath, and then we have joint pain. And I would look at each one of them separately and then hopefully see whether there is one unifying diagnosis that or differential that might explain it all, or whether it's, as so often, more than one disease. Okay, the fever, we have, I think, our IMAID, which is infection, autoimmune, metabolic reasons. Then we have our shortness of breath, because he has hemoptysis as well. He's coughing out blood. The center of gravity for his shortness of breath might be the lung, but it cannot be excluded that it is also the heart. If, for instance, he developed heart failure for whatever reason very suddenly, then accumulation of fluid and even probably coughing blood would be not too surprising. Next is his joint pain. And here we have the clues that there is no morning stiffness, and it's been going on for a month, and there are no signs of Raynaud's disease. So here I was thinking about an autoimmune disease, but I cannot rule out an infection, and that would be an infection that has not been susceptible to the antibiotics that he received. So it's either an infection of a rare infectious agent like tuberculosis, that would explain the shortness of breath, that would explain the fever, but it probably would not explain his joint pain. So I have no unifying picture at the moment, just a few ideas that probably might guide us for future investigations.
That was awesome, Hans. Thank you. Great frameworks. And I think we definitely have like very obvious, next steps that we have to pursue, right, in further elucidating the cause of each of the problems, and refining like which problem we're trying to solve. And to me, like the most prominent problem is the breathlessness and hemoptysis, right? This is a young person, and they have a significant functional limitation because of progressive shortness of breath, and they're coughing up blood. So there's definitely something wrong with their lungs, whether that's the parenchymal compartment, vascular compartment, or multiple. But we need good lung imaging, if available, a CT even to start, in order to make progress on the case. Because there's if you take the severity of the pulmonary symptoms and then superimpose what is obviously significant systemic inflammation in addition, with the fevers, the weight loss, and the achiness, which at this point, you know, we have arthralgias, we don't necessarily see overt arthritis. And while, of course, that invokes the kind of immunologic category of diseases, you can have some non-specific joint pains with various atypical infections as well. So that's not quite a pivot point yet, but definitely a signal that favors, you know, autoimmune diseases as a category. And then just to comment on you know, hemoptysis kind of more generally, that even though kind of if you just take all comers, hemoptysis can be benign and be caused by just sort of focal, you know, bronchitis as the most common cause, just focal irritation of the airway. It can also be associated, obviously, with mass lesions or structural lesions, which in this case are possible. Things like endobronchial, you know, carcinomas, things like that. But in this case, in the setting of significant shortness of breath and systemic inflammation, it's also worrisome for it being sort of a primary vessel problem, whether it's an inflammatory disease complicated by thromboembolism, or you know, vasculitis with diffuse alveolar hemorrhage, or a systemic disease that involves coagulopathy, and it's manifesting with bleeding in the airway. Obviously, there might be a little bit more historical context to here. The social history I'm really curious about, the geography, past medical history, obviously, if there is any, but I guess I've been sort of assuming that this is a previously healthy young person. And then, of course, the vital signs exam and basic labs will be really critical to, again, refine the evolving problem representation. Vijay, you want to move us forward? I'll catch up with the chat, which I'm sure has a lot of great thoughts too, but please give us a little more information.
Yes, sure. Am I audible? Yeah. So past medical history is significant. Patient was recently treated for unprovoked DVT with a bilateral submassive pulmonary embolism 2 months ago. And patient during that hospitalization, the echo, 2D echo showed lesion in the RV, lesion, a mobile structure attached to the RV free wall, probably an RV mass or a hypertrophied papillary muscle was the final report that the echo showed. And the patient was compliant. He was on rivaroxaban, and he was compliant to the therapy, and he was taking it with food. Coming to the family history, there is no similar history in any of the family members. Social history, he is single. He denies any smoking or any. He's not sexually active. He denies taking any substance abuse. Coming to the physical examination, his BP was 120/70. The heart rate was 78. Respiratory rate was 27, and the saturation was 94% on room air. Physical examination was remarkable for in the oral cavity, he was noticed to have oral ulcers, which on further history, the patient says, this is the first time he noticed oral ulcers in his entire life. There is no other genital ulcers or any rashes or any papules or ecchymotic lesions. Cardiac examination was significant for a systolic murmur in the left lower sternal border. I think I'll stop at this.
Great. Thanks, Vijay. Hans, we got some really useful information here. I'm curious, let's just tackle the recent clotting events and this RV something that's in there. What are your thoughts hearing that on kind of how that ties into the month-long history that you and Zaven just dissected? Is it related? Could it be unrelated? What are you thinking?
I think it could be related, and we've already given a very important clue, pulmonary embolism and an unprovoked DVT. Now it's unprovoked. We need to really think about what would have caused the DVT. Is there somewhere a malignancy? And then, of course, if you look at the heart and the systolic murmur in the left lower sternal border, it looks like there is something around the tricuspid valve, and maybe it's a regurgitation of the tricuspid valve due to a myxoma or something like a growth, or even an infection that might send out emboli all over the body. But we have DVTs rather than thrombosis in the arterial system at this point.
Mm-hmm.
Then the dry cough, the shortness of breath might be explainable with the finding of the DVT and the PE, but the multiple joint problems, I cannot make any sense of it yet, because it's the small joints that are being affected, as if it was rheumatoid arthritis, which it is not. So there's no morning stiffness, so there's probably some surprise coming up too. So at this point, I think I need some teaching from others. I'm looking forward to the labs and see what's coming out of the WBC and the platelets. That might give us another hint, and further imaging probably.
Yeah, I'm totally with you, Hans. Hearing that these clotting events happened a month before his fevers and dyspnea started, I would challenge that the clots were unprovoked to begin with, right? I think, it would be for this otherwise previously healthy 24-year-old guy to have thrombosis and then to have systemic illness. It's really hard not to assume these are related together. So my initial reaction is sort of challenging the unprovoked nature of these and wondering, has the systemic driver for what's been going on actually been going on for a couple months now, manifesting first with the thromboses? The use of the systemic anticoagulant, I think, is very helpful to know when it comes down to why he has hemoptysis. You and Zaven talked about a nice sort of anatomic approach to the hemoptysis itself, thinking about whether there's a parenchymal problem versus a vessel problem. And we know already he's had a vessel problem recently, right? He had submassive PEs. So is recurrence of that, despite being on anticoagulation, something that's driving some of the hemoptysis and respiratory symptoms? But we already got a wonderful kind of rheumatologic review of systems as we face this arthritis that is sort of making us think about rheumatologic conditions and potential small vessel disease. So he already had a pulmonary vascular problem. Whether that's why he's dyspneic and having hemoptysis now is hard to say. And we know he's got a iatrogenic coagulopathy right now. 100% agree. Knowing what his platelets are and what his coagulation parameters are is going to be helpful. But knowing that this hemoptysis started while he was on systemic anticoagulation takes a little bit of the specificity away for me, just knowing that whatever pulmonary process he may have, he's going to be a little bit more prone to bleed because he was already on the anticoagulant. So I think it actually kind of broadens almost the differential diagnosis for what's going on in the lungs, knowing that his blood has been thinned already. And so really many problems in the lungs could then result in hemoptysis, even without kind of profound seriousness of it. And yeah, the oral ulcers, right, is a really important exam finding here that does kind of make us, again, worry about what is driving the systemic inflammation. And the quick categories that come to mind when thinking of oral ulcers are they traumatic at all? Which it sounds like that's not the case. Are they related to inflammation from infection? Things like herpetic ulcers, you can get syphilitic ulcers, other sorts of things. Are they non-infectious inflammation? Ulcers that can come with small vasculitides like enchovasculitis, can come with vasculitis like Behçet's, or can come with inflammatory bowel disease that was previously undiagnosed, and this happens to be one manifestation. Malignancy would be a category that hopefully for this young guy is less of a concern to drive this picture in the ulcers currently, but is out there. And then are the ulcers just unrelated aphthous ulcers, or just very common and can happen all the time, even without associated conditions? It's interesting to me that he didn't notice these, and that perhaps indicates that they were painless. So the fact that they're painless ulcers fits less with my illness script for aphthous ulcers, which I think typically are painful. But Zaven, am I right on that? That usually they are, because they're kind of local inflammation, they hurt generally.
Yeah, usually from what I know, I think most causes of oral ulcers are, you notice them. Lupus is the one cause in my mind that can cause painful or painless ulcers.
Yeah. So to me, the most compelling category that we'll explore more as we get more data, maybe is the sort of connective tissue category, as a way to explain what seems to be multifocal, multi-system inflammation with being prone to thromboses, having ulcers, having some joint inflammation, and these fevers. But we'll see where you take us, Vijay.
Amazing thoughts. I'm just presenting the way how the case evolved over a period of time. So coming to the labs, the hemoglobin was 12 grams with an MCV of 78 and MCH and MCHC being normal. WBC was 5.4 and the platelet was 2.86. Coming to the coagulogram, the PT was 15.9 and an INR of 1.2. The renal chemistries and the liver chemistries were within normal limits. So because we were of similar thoughts of, is there a recurrent pulmonary embolism or is there something else? So we got an ECG which showed a sinus rhythm. The transthoracic echo showed a similar finding of the nicogenic content attached to the RV valve and with RVSP of 35 millimeters of mercury with no significant RV dysfunction or LV dysfunction. Compression ultrasound of the lower limb showed acute thrombus in the bilateral superficial femoral veins. CT pulmonary angio showed a pulmonary artery to aorta ratio of more than 1 and a new acute segmental thrombus in the bilateral lower lobes with mildly dilated right bronchial artery and multiple GGOs in bilateral lower lobes. So, further suspecting a hypercoagulable state, we got an ANA, ANCA, anti-GBM, antiphospholipid antibodies, activated protein C for a factor V Leiden, and prothrombin gene, all of which was negative, and homocysteine levels were also normal. Yeah, I'll stop it.
Wow. Hans, what stands out? Both the negative and positive things that we've heard on this aliquot.
The first thing that stood out for me was he's on rivaroxaban, and somebody can teach me here, but his INR is 1.2. So it doesn't seem to really anticoagulate his blood. Then we have an echocardiogram where we have something attached to the right ventricle wall. Then we have ultrasound lower limb, and there is a thrombus. And we have in his lungs as well the PE. And then what stands out is the finding that antithrombin, protein C, protein S, all are within normal limit. But I think we don't have the antiphospholipid workup for cardiolipin.
Antiphospholipids was normal.
Was normal. Okay, so
Normal.
that one is normal as well. So I have no explanation what is going on other than maybe a severe inflammation somewhere in the body. So maybe an ESR and C-reactive protein might guide us a little bit. And then the WBC with 5,400 normal. normal red blood cells, maybe on the lower end, and normal platelet. And everything else looks like it's normal. But the thrombus and what we found in the heart, is it a thrombus or is it a vegetation? I have no idea what it could be. Maybe a blood culture, which is not too expensive, might, if it's negative, it should be repeated again, but maybe it'll give us an idea beyond just thinking about thrombosis in the body.
Excellent, Hans. Yeah, love all of that. I think, you know, for how sick this person is, I think, you know, any test is fair game, right? And this definitely doesn't seem like a sort of a routine daily or weekly or even monthly diagnosis. So I think at this point, with something being clearly terribly wrong and thus not having super firm leads yet, with pretty good initial workup, like any test, inexpensive or expensive, I think is fair game and very valuable in trying to make a diagnosis. Yeah, I think there's definitely thrombus, right? There's sort of the PEs, they're in the lower extremities, and the RV mass. You know, a lot of times when you see a mobile mass in the RV, that's called a clot in transit, right? But usually it's you know, it's very mobile and it's not necessarily attached to anything. It came from the lower extremities and it's on its way traveling to the lungs. It's just kind of like stuck in the flow patterns of the more commonly RA, I think, than RV. But the fact that on two different echocardiograms, there's sort of it seems like it's actually stuck to the wall. It's a bit weird for just a clot in transit, and it invokes whether it's a clot, you know, that or potentially originated in the RV, which would then invoke, yes, as some people were talking about, sort of hypercoagulable conditions where multiple clots are forming. The leg vein clots definitely formed in the leg veins, right? But then what if you're also forming thrombi within the cardiac chambers? I think at some point someone was alluding to apparently a recent case I must have missed, but of eosinophilic myocarditis, which is notorious for being extremely sort of prone to cause endomyocardial fibrosis and embolization from there. And I think somebody was also asking for a differential, which Vijay, I'd love to see too, on the serum white blood cell count. But then thinking, as Hans, you said, sort of trying to think beyond just clots, and could this be a you know, a mass or some other process that is causing both inflammation and the hypercoagulable state? You know, intracardiac masses oftentimes are primary cardiac tumors, but can also be metastases to the myocardium or endocardium, and most commonly actually pericardium, which isn't the question here, but you know, I think sort of so myxomas, which are one of the more common primary cardiac tumors, can I think cause fevers, but I don't know if they would cause this degree of sort of systemic inflammation. I would kind of be surprised. And the RV is a weird chamber within which to see a myxoma. It's usually in the atria. And again, the sort of visual characteristic that's described does not seem consistent with that. You know, lymphomas and melanomas can behave very oddly and go to different places. I think you know, it's sort of easy enough potentially to do a, you know, a skin exam to look for, you know, a primary site. And then if there is a hypercoagulable state, kind of back to the clots, sort of rethinking what we've missed so far. I love this framework from Robbie that I won't do justice, but that a lot of hypercoagulable states are reflected in the CBC. The sort of the ones that cause, again, multifocal arterial thrombosis. You either see the myeloproliferative disorders with thrombocytosis and, you know, erythrocytosis and a high white blood cell count, abnormal differential, etc. Or in the case of catastrophic antiphospholipid syndrome or heparin-induced thrombocytopenia, you see thrombocytopenia or even a bicytopenia with MAHA. So it's either those things, either there's a footprint in a CBC or it's cancer. And then we kind of go back to, again, the possibility of malignancy causing the hypercoagulation, the systemic inflammation and the weight loss, and then intracardiac masses, either via direct metastasis or more commonly on the valves than other parts of the endocardium, sort of the sort of merantic endocarditis, which is sort of a sterile fibrinous endocarditis, but again, usually happens on the valves rather than on the free wall of the endocardium. So I'm a little bit stuck, sort of wanting to potentially revisit again the full list of hypercoagulable states and see what we haven't necessarily tested for, and then do sort of and then take a list of malignancies, common and uncommon, that might occur in a 24-year-old male, and see which of them it is worthwhile and easy to test for, testicular exam, skin exam, but even potentially considering further cross-sectional imaging of the abdomen, looking for other kind of clues and pivot points. Yeah, I think I've lost track of a couple of threads, and I'll sort of tag Steph and Hans and back in to see the GGOs and other whether you think that's signal worth pursuing.
My thought was hard to say, right? We know he's got clots and he's been bleeding a little bit. So is that just blood in there, or is there a separate primary pulmonary process? I think hard to say. I think the exam finding of the ulcers, I'm just having trouble tying in to a lot of those ultra hypercoagulable conditions you mentioned, and coming back to, again, some vasculitides potentially being on the table still in the absence of, even with a negative ANCA, and wondering still if that is there. I mean, we'll likely need a biopsy of some tissue at this point then to figure out if there is vessel inflammation. But the ulcers stand out to me as something that just isn't explained by some of those other hypercoagulable states that were mentioned. Want to give us more people? Oh.
Which Behçet's is one. It can be one of those hypercoagulable states. And now that I'm sort of looking at it, like what doesn't fit with Behçet's?
I guess we don't have a recurrent ulceration history at this time. Maybe that'll come out later, but that's, at least missing at this moment with the story. BJ, give us some more.
Amazing thoughts. So we were also confused on managing this patient when the patient is bleeding despite anticoagulation and the new thrombus. So we are worried for a lot of things. So like people are mentioning in the chat, I forgot to give a differential. The differential was normal. There was no eosinophilia. The HIV, HbSAg, and HCV were negative, including the VDRL. It was negative. And the blood cultures, 3 sets of blood cultures were negative. So characterizing 2 things, coming to is it a hypertrophied papillary muscle versus a thrombus or a vegetation? So we got a cardiac MRI that showed a small organized thrombus in the right ventricle, and some areas of T2 hyperintense areas in the bilateral hilar location, perihilar location, and in the superior segment of the right lower lobe. So concerning, we reviewed the CT again, which was reported. And while reviewing it, so we found there are multiple pulmonary aneurysms. There are small pulmonary aneurysms located in the right lower lobe and segmental branches of the right middle lobe and left upper lobe. The pathology test was negative, and the repeat CT done after some time showed a resolution of the hemorrhage. The HLA-B51 was positive. However, there was no any oral ulcers or genital ulcers that we had. So I looked at this, and then reveal the final diagnosis.
Can I just ask Vijay that what was the T2 hyperintense areas in the hilar and superior? What was sort of the
They were concerning for pulmonary aneurysms.
for aneurysms? Okay, and then subsequently the repeat CT showed that they were.
And from the same.
What do you think, Hans?
I'm going to learn something new because now I need a second computer and look up at HLA-B51 positive. This is a strong clue for probably an autoimmune disease of some kind. And what kind it could be, I don't know, but I have a feeling it could be a vasculitis. At first, I thought about GPA and wanted to check out whether with a UA we could find a little bit more, because we have affected with ulcers the mouth, then the lungs, and maybe even the kidneys, causing a hyper-inflamed state, which then in turn can cause this anticoagulant resistant coagulation state. So this is something new, and I think it's an autoimmune disease that I don't know.
Yeah, we're getting that signature, aren't we, Hans? The HLA-B51, you're totally right, is associated with rheumatologic disease, and specifically, correct me if I'm wrong, Vijay, in your teaching, I think is one of the most common associated findings for Behçet's in particular. So potentially sort of making that diagnosis even more compelling. So I think, hearing this additional information about the HLA-B51 and then these aneurysms, one thing I don't know, and Zaven, tell me what you think, Behçet's is a vasculitis that can affect vessels of all sizes. And so can it affect the pulmonary arteries enough that they actually distort and dilate and become aneurysmal? I have not heard of that specific complication, but one could think if your vessels are inflamed enough that you could actually get kind of malformations in the actual structure. So the pulmonary aneurysms may fit well with that kind of vasculitis. Behçet's is tricky because as far as I know, there's a set of criteria that patients need to meet, but there's otherwise no slam dunk way to diagnose it. But we'll probably hear in your teaching, Vijay, what those criteria are, but I think we're getting close with ulceration, although again, the history of having recurrence of this is absent, but that doesn't mean it potentially wasn't there in the past. You guys did the pathergy test, which is essentially the test of pricking the skin and seeing if there's subsequent, it's, I think, using a specific needle size, right? And actually seeing if any skin lesions develop there. We're missing kind of other skin lesions. We're missing kind of eye stuff. We're missing genital stuff at this time, but with this very, very fulminant picture of thromboses with that HLA type, as well as evidence of vessel damage on imaging. I wonder if we're at least getting into intermediate probability. Zaven, do you want to flesh out the illness script for that at all and help us see what fits versus doesn't before we hear how things went?
I think, yeah, this case is amazing. No, you did a great job just reviewing sort of the various manifestations of Behçet syndrome, and in trying to see whether this fits or not. In my mind, I was asking, you were kind of asking, the chat sort of was giving some answers about the key question of, what is the sensitivity of the most common manifestations of these rare disorders that we consider, right? And, if one were to say that 99% of patients with Behçet's have genital ulcers, so it's almost like a sine qua non, right? Like, just like we saw the ANA was negative and the word lupus was not mentioned again, right? Like, but that doesn't seem to be the case. I was kind of surprised too, Mark, that someone wrote only 70% of patients with Behçet's have genital ulcers, right? So, but I kind of want to shift to more of like a process point and just reflect on again, the importance of sort of solving the right problem and of trying to find the key sort of pivot point in a case around which to try to build a differential. And credit, Vijay, to you and other treating team members who sort of re-reviewed imaging with radiology. There's so much value to that, right? I've never regretted doing that, always been so glad. And finding what to me is a huge pivot point. Anytime you hear something that you haven't heard of in 3 months or 3 years or ever, pulmonary artery aneurysms, right? Like you should assume that that is really important signal. So what I did when I heard that, I did pull up another computer, Hans, and sort of Googled the etiologies of those, and some of it kind of refreshed me on stuff I thought could cause that, tuberculosis, other atypical bacteria can cause those like so-called Rasmussen aneurysms, right? Vasculitis, Steph, and including Behçet's can be a cause. But then I saw something that I'd never heard of, or maybe I had and I'd forgotten, but what apparently everybody else is is very familiar with. People are mentioning this Hughes-Stovin syndrome in the chat. Yeah, it actually seems like a very, very good fit. Some people pasted quick descriptions, but I was reading here that a cause of pulmonary artery aneurysms, fever, recurrent venous thrombosis, thrombophlebitis, and sort of thought to be potentially a variant of Behçet's or a related disorder, autoinflammatory disorder. So it seems like sort of a good fit in this case, and both that and Behçet's are associated with the HLA haplotype. So yeah, that's my best guess of it being sort of in this category of disorders and a good fit for this epidemic syndrome. And really excited to learn more from Vijay and from reading later on. So take us home.
Amazing thoughts. So this is where we landed as well. So there are some things, that's why I named the title as complete or incomplete. So the final diagnosis was Hughes-Stovin syndrome. For a few reasons that it did not completely fit Behçet's, because there was no recurrent oral ulcers, which is an essential criteria that is required to diagnose them. And the other ulcers, like any genital ulcers, none of that was present. And pathology test, although it is having a high specificity, it could still miss diagnosis of Behçet's in about 3 to 4% of patients. But however, what is very unusual for Behçet's here is the involvement of pulmonary artery. The pulmonary artery aneurysms or involvement is seen in about less than 5% patients of Behçet's. That is one of the rarest manifestation. And even intracardiac, very interestingly, intracardiac masses have been described. So this fits into that description of having an organized thrombus. Is exactly how it is described. A young male, and it is common in young males, and it is commonly affecting the right ventricle, and it also causes organized thrombus predominantly in the arm. So because of multiple pulmonary aneurysms, so this is what was the diagnosis considered. And so subsequently, there are a few interesting points with Hughes-Stovin. So it is considered a variant of Behçet's. There is still a debate whether it is part of Behçet's or is it an evolving part of Behçet's. Maybe the oral ulcers come later on in life. So there is a debate between, is there two distinct entities or is it the same? This is one. Second thing, this is mostly characterized by a limited involvement of predominantly the pulmonary vasculature and thrombophlebitis. There are 3 phases described. Usually, initially, patient develops thrombophlebitis, then they develop pulmonary aneurysms, and then the third stage wherein patient has death, most commonly because of massive hemorrhage or pulmonary artery hemorrhages. So because somehow we could pick this up early, so we started this patient on low dose steroids and immunosuppressants, and somehow I could not get the images, very beautiful images, wherein after 3 months of follow-up, the aneurysms had completely disappeared completely, and patient is completely doing fine.
That's amazing. That makes this fantastic case, just cherry on top, the fact that, you know, the patient got better with treatment, and yeah, what an amazing journey. Curious, Hans, what reflections you have, and Steph?
Yes, when I saw the oral ulcer, my first thought was Bichette, but I missed everything else. The eye involvement, the genital ulcers, but everything else might indeed fit. But thank you so much, you Stovens. It's endless learning, but it makes it so fantastic and interesting. And I would like to thank Vijay for this interesting case. Maybe
Yeah.
would have.
I was just going to say to sort of bring in the discussion of pulmonary aneurysms and what caused that was just a really, really great learning opportunity for me in particular. So I really appreciate it, VJ. Out of curiosity, what was he put on besides steroids for immunosuppression?
So what is the recommendation is cyclophosphamide or azathioprine. So we started him on cyclophosphamide, oral cyclophosphamide, and patient did well.
And was his anticoagulation changed at all, or was he kept on
So
the?
we did. So we continued the same anticoagulation because we thought the entire process is secondary to vascular cause. So we continued the same thing, and follow-up CT showed resolution of the aneurysm as well as the thrombus. So here we also have a dilemma whether to continue a lifelong anticoagulation or we just leave it at this. So like shared decision between the patient and us is what we are subsequently planning to do.
Wow. Fantastic. Thank you so much. What an amazing case. Learned a lot from the chat too. Kuchal, we'll turn it over to you to wrap up the teaching points.
The chat is on fire, and as usual, it's like one of Vijay's classic case. And a couple of teaching points which I just want to go over is one, when a patient is presenting with the PE and with a history of venous thrombosis, then venous thrombosis itself could be the cause of the PE, and which could be causing also. We'll have to rule out if the patient is having APS and also start treating them with warfarin. And the other thing is that in this patient, when they're having unprovoked DVT, we would have to rule out rheumatological conditions. And there was a lot of discussion about NSAIDs with the DVT, but then this patient, there's only rarely they have less than 5% have pulmonary vessel aneurysm, and it's usually associated with mutation in HLA-B5 or B51. And the patient hasn't got recurrent ulcers, which are usually present in 70% of the patients. And the way they diagnosed him with the Youth-Stoven syndrome is that he's having organized thrombus in intracardiac area and involvement with pulmonary artery. And they would die with massive pulmonary hemorrhage if it wasn't treated early with immunosuppressant with steroids, that as Vijay and his team had managed to do. And the other thing which I found very interesting was in NSAIDs, there would be a stable thrombus in femoral vein, which is different from the other regular DVT.
Amazing. Thank you, Kuchal. Thank you, Shreyas, for scribing and keeping up with all the many, many points of this case. And Vijay for bringing such a really fantastic case. Really, really enjoyed and learned a lot.
That was awesome. Thanks, everybody. Have a great day.
Take care, everyone. See you next time. Bye.